right. Good afternoon, everyone, and welcome to today's webinar, Policies and Strategies to Address Infectious Diseases. My name is Charlie Severance. I'm a policy specialist in NCSL's health program, where I cover issues related to infectious diseases, substance use disorders, and other public health topics, and I will be your moderator for this afternoon. On today's webinar, after some brief introductions and housekeeping items from me, we have the opportunity to hear from Sarah Ziegler, the Associate Director for Policy in the Office of Policy Planning and Partnerships in the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention at the Centers for Disease Control and Prevention, or CDC. We know in these conversations that it's often helpful to hear from other legislators. So we also have the opportunity today to hear from Representative Alex Valdez of Colorado and Delegate Matthew Rohrbach of West Virginia. After each of those presentations, we will also have time for question and answers. And you can ask a question at any time by opening the chat function in the bottom left of your screen. To go ahead and start building some familiarity with that function, I'm going to ask everyone on the line with us today to go ahead and open up that chat box and type in the state you are joining us from today. And again, at any time today, you can ask a question, and we'll just save those for those specific question and answer periods after each presentation. I would also like to direct your attention to the Resources tab at the top of your screen. There you can access and download today's PowerPoint presentation, as well as some other resources that we have compiled for you. And we will also go ahead and drop the links to those specific resources in the chat box. You can also access speaker bios today by clicking on the Speaker tab. And again, you can access those at any time. And it does look like folks are able to use that chat function, and we've got a bunch of folks from a bunch of different states, so that's great to see. A few other notes. Our webinar platform is designed to work best on Google Chrome. You can try and use another browser. However, if you're having trouble, we do suggest that you first log off of that browser and then log back in on Google Chrome. If you are still having difficulty, you can email us at registration@ncsl.org, and someone will be able to assist you. I do also want to note that today's webinar is being recorded and will be on our website in about a week. Before I get any further, I do want to thank the Centers for Disease Control and Prevention for their support of our public health webinar series. And specifically, I'd like to thank the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention for their support of today's webinar and their partnership with NCSL. This is the 7th in a lineup of about 9 public health webinars that we have offered in the latter half of 2020 and the beginning of 2021. Our next webinar is coming up on January 8th. Welcome to the legislature, what you need to know about public health. And that will really be a primer for newer legislators, but also legislators newer to health. If you're interested in any of the other public health series webinars, you can also watch those recordings on our website. And with that, I'm going to go ahead and turn things over to the person who you all logged in to hear from today, Sarah Ziegler, the Associate Director for Policy at the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention at the Centers for Disease Control and Prevention. So Sarah, I'm going to let you have it now.
Thank you, Charlie, and thanks for saying that mouthful on the introduction about our National Center. You saved me. And thanks to NCSL for the invitation to present today. And it's wonderful to be a part of this session with Representative Valdez and Delegate Rohrbach. And thank you all for joining us from across the country to spend the next hour discussing this important topic on addressing infectious diseases. Today's presentation will focus on sharing information about the opportunities to save lives, protect people, and reduce health disparities while maximizing our impact through the implementation of cost-effective strategies by effectively addressing infectious diseases such as HIV, viral hepatitis, STDs, or sexually transmitted diseases, and tuberculosis. As we explore this topic, it's important to recognize the time in which we are living right now, as we face the greatest public health threat our nation has seen in 100 years due to COVID-19. While we must continue to fight the pandemic, we also can look for opportunities to build a stronger public health system and expand innovative strategies that not only help to stop COVID, but also other infectious diseases. As part of my role at CDC, I have the opportunity to focus on a portfolio that includes HIV, sexually transmitted diseases, tuberculosis, and viral hepatitis. Almost 90% of the infectious diseases reported to CDC fall within this portfolio. And these infectious diseases disproportionately affect people of color, gay and bisexual men, and transgender individuals. Prevalence of HIV is over 150 times higher in men who have sex with men and transgender women than heterosexual men and women. HIV incidence rates are 8 times higher among African American persons and 3 times higher among Hispanics and Latinos than white persons. Additionally, where one lives makes a difference, with a disproportionate burden of HIV concentrated in the southern parts of the US. Rates of acute hepatitis C are significantly higher for American Indian and Alaska Natives than other populations, although there is a significant burden amongst white populations as well. Asian persons represent the largest proportion of TB patients, followed by Hispanic persons. Many systemic and structural factors have exacerbated racial and ethnic health disparities in infectious diseases. And these include, but are not limited to, barriers to accessing healthcare, stable housing, work circumstances, and education. And at the same time, we have access to the most powerful prevention and treatment tools in history, and we know where infections are spreading most rapidly. If we all, state, federal, and community-based partners, implement strategies with an eye towards reducing health disparities and increasing health equity, we can succeed in reinvigorating public health systems that can stand in crisis, while achieving massive reductions across multiple infectious diseases. Millions of Americans are living with HIV, viral hepatitis, sexually transmitted infections, and tuberculosis. Over the next few slides, I will share some information about the challenges we face tackling these infections and what strategies, if implemented, can make a difference. HIV has cost America far too much for far too long. Over 700,000 Americans with HIV have lost their lives. And today, every death from HIV is preventable. And each one highlights the failure of our public health, medical care, social, and economic structures. About $28 billion is spent annually by the US government on HIV, the vast majority of that on care. So good HIV prevention saves lives and money. And lastly, without intervention, over 350,000 Americans will get HIV in the next 10 years, with an individual's lifetime medical care cost equating to approximately $500,000. Preventing HIV matters for the people who get it, for their loved ones, and for society as a whole. People with HIV who don't know their status can inadvertently transmit it to others. In the US, the average time from infection to diagnosis is 3 years. It is less than it used to be, but it's still not good enough. HIV testing should be normalized, as common as screening for cholesterol and diabetes. Data modeled in this table shows that 51% of people with HIV who are virally suppressed, meaning they have no detectable viral load in their system, are associated with no new transmissions. However, the 38% of persons with HIV who are either undiagnosed or not receiving medical care are associated with 81% of new transitions. We need to enable people who are at highest risk to be tested at least once a year through clinics, community organizations, at home, and other innovative approaches. Yet these practices are not done enough. Additionally, Americans are suffering from unprecedented levels of sexually transmitted diseases. In 2018, the latest data that CDC has, the highest number of STDs were reported to CDC. Chlamydia, gonorrhea, and syphilis are curable with antibiotics, yet most infections go undiagnosed and untreated, which can lead to severe adverse health effects, including infertility, ectopic pregnancy, stillbirth in infants, and increased HIV transmission and acquisition. In 2018, new STDs totaled $16 billion in medical care costs alone. Having syphilis, gonorrhea, and chlamydia also doubles the chance a person will acquire HIV. And similarly, they double the chance a person with HIV will transmit to their partner. The proportion of HIV that is caused by STDs in the US is high because of the overlap in populations. For example, half of men with syphilis have HIV. To get ahead of this, screening works. Screening for STDs followed by treatment, if needed, prevents the spread to others. In the case of syphilis, routinized screening of pregnant people can prevent infant mortality and save even more money in the healthcare system. An example in Texas, in 2019, Texas began requiring physicians to test pregnant people for syphilis 3 times. The first prenatal visit, during the 3rd trimester, and at delivery. This strategy allowed for more contact with the healthcare system to quickly identify costly issues and initiate proper treatment. Increasing incidents associated with the nation's opioid and injection drug use crisis are of great concern with hepatitis C. Ongoing efforts are needed to prevent hepatitis C transmission. This past year, CDC broadened its testing recommendations to include universal screening for all adults at least once in their lifetime, as well as screening for all pregnant women during pregnancy. Other screening recommendations were also published for people with certain conditions and/or exposures. Improving awareness of hepatitis C infection status is critical, and our efforts to ensure that all people with hepatitis C have access to short-course, well-tolerated curative therapy. And again, ensuring that people are screened for hepatitis will result in billions of dollars being saved by implementing curative treatment earlier in an individual's illness and saving them from costly interventions. We still face a crisis involving injection drug use of opioids such as heroin, fentanyl, and prescription opioids, as well as other drugs such as methamphetamines and cocaine. Opioid-related overdose deaths were almost 6 times as high in 2018 as they were in 1999, and infectious diseases have dramatically increased as a result of this crisis. What's more is that the COVID-19 pandemic has only accentuated this crisis. Both fatal and non-fatal overdoses have increased since the pandemic began, and services for people who use drugs have experienced substantial challenges during this time. Though the population is small, the long-standing decline in HIV diagnosis among persons who inject drugs in the United States has now stalled. We're also seeing an impact on STDs too. Several sexual behaviors and sexually transmitted infection diagnosis were associated with increased odds of engaging in injection-related behaviors. And aside from HIV, hepatitis, and STDs, other infections like MRSA or endocarditis, an infection of the heart, are extremely costly to the healthcare system and can be prevented with actionable policies that link people into testing, supportive treatment, and care. To this end, beginning with Scott County, Indiana in 2015, we've seen a growing number of HIV outbreaks among people who inject drugs, both in nearby areas like West Virginia or the Cincinnati area, but also in metropolitan areas of all sizes, with responses efforts ongoing in and around Portland, Oregon, and Philadelphia. The impact of these outbreaks for individuals and for the community is profound and can be measured in many different ways. The medical costs associated with the over 200 new cases identified in the 2015 Scott County outbreak is estimated at over $100 million. And that cost is shared by the state budget, specifically the Medicaid budget, which is often needed to facilitate the HIV care for these individuals. This map indicates a few of the outbreak and cluster investigations that CDC has collaborated with states in addressing. This is not a comprehensive summary of all of the recent HIV outbreaks or clusters. Public health works when we together address factors that lead to massive numbers of infections and health disparities. During the mid-1980s, 130,000 people were infected with HIV each year. That decreased to a relatively stable number until 2008, when concentrated efforts to shift funding to the most effective interventions and affected populations in geographic areas resulted in an 18% decline in incidence to only about 40,000 new infections per year and resulted in saving about $15 billion in cost over time. In this graph, hepatitis B deaths are associated with the pink color and hepatitis C deaths are in green. So while a minute ago I showed you information that said hepatitis C infections are increasing, they are. What we are seeing is that less people are dying of the disease since the advent of effective hepatitis C curative treatments. Innovative strategies and testing and linkage to treatments, in addition to innovative financing models, can lead to reductions in deaths attributable to viral hepatitis. What is critical here is to ensure there is access and equitable access to this therapy. Innovative policy with your state's Medicaid agency can be explored, as a few states have already done this. The cost of treating hepatitis C has historically been incredibly high. A number of states have considered innovative care and financing models. For hepatitis C, treatment needs to be handled at the population level. We must try to reach as many patients as possible, as fast as possible. So in New Mexico, the Extension for Community Healthcare Outcomes, or ECHO model, was developed to improve access to complex chronic disease and specialty care in rural and frontier areas of New Mexico and in its prisons. ECHO is an innovation that allows access to the centralized wealth of subspecialist knowledge and skills found at the University of New Mexico, which is the state's only academic medical center. Through the co-management of patients, rural primary care providers learned about best practices in treatment for hepatitis C and worked through telehealth technology to facilitate participation. There have been over 5,000 patient consultations for hepatitis C, and they've been working with community providers, presenting patient cases, and receiving expert support and co-management. This includes clinical evaluations and screenings to determine and promote patient readiness, with periodic review of cases that are not treatment ready to ensure appropriate linkages to other services. Louisiana and Washington have adopted the subscription or Netflix model, where there is a set fee guaranteeing the drug manufacturer a specific revenue amount, and there will be a provision of curative treatment tied in with promotion and support for the workforce that will be needed to reach people that have hepatitis C over a specific period of time. The Centers for Medicare and Medicaid Services, in its announcement approving Louisiana's plan, encouraged other states to apply for approval for subscription drug payment models for other expensive treatments. Such agreements can give states more certainty on their Medicaid budgets. CDC recommends that all adults get tested for HIV at least once, and people at higher risk get tested at least annually. Yet these guidelines have been sadly ignored by many. One way to increase testing is to weave it into existing systems. When the Veterans Administration adopted CDC's testing recommendations, they doubled their testing rates. And the facilities that included automatic electronic health record prompts increased testing fourfold in a 2-year period. Ideally, HIV screening is conducted on samples drawn for other reasons, like a complete blood count or hemoglobin A1C. Similarly, New York was concerned about people not getting tested for hepatitis C. They passed a new testing law in 2014, and testing increased 52% in baby boomers. By making the healthy action easy, when people are already receiving health care, it takes out the individual effort for patients and providers and can improve outcomes. We can focus on centering our public health approaches to reach people where they are, and we can address multiple infectious diseases such as HIV, hepatitis, heart and fungal, and other bacterial infections at the same time. To deliver services that reach populations at increased risk, though, we have to be willing to change our systems. And the process will have to address substance use disorders, including the pervasive stigma and barriers that exist to providing treatment. We'll have to overcome challenges related to housing instability and incarceration that make it difficult for people to achieve stability and sustain progress in their health and lives. You can see here our core strategies for reducing the number of infections that are most often linked to drug use, most notably syringe services programs, or otherwise known as needle exchange programs. And substance use disorder treatment sites can have a profound impact on reducing the number of infectious diseases. These settings have high potential for injection drug use related encounters, and they can implement routine or opt-out screening and can screen for multiple infections at one time. By supporting our health departments to effectively respond to clusters of these diseases, we can speed up testing and linkage to treatment and stop diseases in its tracks. We also know it's important to have primary prevention. When we focus on school-aged youth, our efforts can be cost-effective. Data suggests that for every $1 invested in school-based HIV and STD prevention programs, over $2 in medical and social costs are saved. Early interventions in education can reduce behaviors that may lead to acquisition of infectious diseases later in life. Syringe services programs have the power to cut hepatitis C and HIV transmissions in half. and also decrease bacterial infections that are caused by unsafe injection practices. In addition to providing sterile injection equipment, these programs provide education about safer injection practices and can catch infections earlier and treat them more quickly. A recent study estimated that implementing these types of programs in Philadelphia averted over 10,000 new HIV infections in the first 10 years of operation and yielded a one-year return on investment of almost $250 million. Syringe service programs are powerful tools for helping people overcome substance use disorders. Program participants are 5 times more likely to enter treatment for substance use disorder and 3 times more likely to stop using drugs than those who don't use a program or don't have access to it. We have nearly 30 years of evidence and experience with these types of programs in communities of all shapes and sizes, demonstrating their effectiveness. As syringe service programs can keep communities safe. State and local laws can facilitate access to clean injection equipment and other services like syringe service programs for persons who inject drugs. Laws can be related to authorizing the full operation of a syringe service program, modifying drug paraphernalia laws to decriminalize the possession of needles or syringes, authorization of the retail sale of syringes for people who inject drugs at the pharmacy counter without a prescription. These policy strategies can strengthen these programs. They can increase provision of services and help close the access gaps while also supporting an evidence-based strategy known to reduce new HIV and hepatitis infections. We know we can do better when it comes to increasing services to screening populations that are at risk. All people with hepatitis B and C should know their status and be treated. Less than 30% of the substance use treatment facilities who see a high volume of people who inject drugs offer screening for HIV or hepatitis C. Accelerated efforts to diagnose, treat, and prevent HIV infections are urgently needed. In 2019, CDC reported that 154,000 people with HIV, or 14%, are unaware of their HIV status. Without proper screening and linkage to care, these individuals are able to spread HIV, often without knowing it, to others. Further, only about 18% of the 1.2 million people who could benefit from pre-exposure prophylaxis, or PrEP, have received a prescription. PrEP is a once-daily medication that can prevent up to 99% of HIV infections. Improving PrEP coverage will require targeted improvements in PrEP awareness, prescribing practices, and use in underreached demographic groups, especially among young persons, Blacks, and Hispanics and Latinos. Among those with current HIV infection, nearly 2/3 of individuals have their HIV under control or are virally suppressed. It is imperative that people with HIV have adequate access to proper medical care to make sure their viral load is suppressed. When a person has an undetectable viral load, there is effectively no risk in transmitting HIV sexually to others. Again, I just want to make sure I repeat that. When a person is virally suppressed with HIV, there's effectively no risk that they can transmit HIV sexually to others. We can normalize HIV and other infectious disease testing by making it routine or opt out. Screening for HIV and hepatitis should be as normal as screening for other conditions. New York state law requires healthcare professionals to offer all patients between the ages of 16 to 64 an HIV test. The law applies to anyone receiving treatment for a non-life-threatening condition in a hospital emergency department, or a primary care setting, such as doctor's office or outpatient clinic. A patient can consent to rapid HIV testing by telling the provider that they agree to be tested. Similarly to the 2014 hepatitis C law that began in late 2016, New York began normalizing routine screening for HIV. Updates to New York's public health laws and regulations require that patients must be orally informed that the test is going to be conducted and have the right to refuse the test. Subsequently, toolkits and provider resources have been developed to ensure implementation of this rule and make sure we can maximize the detection of HIV in clinical settings. Additionally, scope of practice policies can expand for certain medical providers, has the potential to reach many more people with well-needed treatment and other interventions like HIV, pre-exposure prophylaxis, or PrEP. Allowing a nurse practitioner or pharmacist to perform the proper evaluations to begin treatment or prevention medications can greatly increase access for rural living Americans and for those who are underserved by our medical system. Representative Valdez will soon speak about an effort in Colorado to do exactly this. These policy strategies can permit pharmacists to prescribe and dispense HIV prevention drugs. Further, standing orders which will allow pharmacists to dispense HIV PrEP can significantly improve PrEP coverage, especially among those who have less access to this critical medical intervention. Self-testing and self-sample collection for screening for infectious diseases like HIV and STDs and hepatitis is another powerful tool, especially during times when health department or medical provider capacity is strained or unavailable, like we are experiencing right now. Health departments can have a large role in facilitating this access if resource supports such efforts. Research shows that the linkage to care after receiving a positive diagnosis when it's been conducted via self-test are not affected. These strategies can be applied to multiple disease areas, including COVID-19. Evidence shows that a campaign in which HIV testing is linked with COVID-19 testing could substantially reduce HIV incidence and reduce direct and indirect healthcare costs attributed to HIV. Finally, I want to highlight one special setting where we can make a real impact on addressing infectious diseases, correctional settings. Evidence indicates that between 1 and 2/3 of inmates in correctional settings report a history of injection drug use before incarceration. The opportunity to test, vaccinate, and treat individuals at increased risk while they are in the controlled environment of a correctional facility is a good policy for both individuals and communities. On the right, states with the darker shades have a higher prevalence of hepatitis C among those incarcerated. Without screening programs, persons will likely be diagnosed later in the course of their infection, resulting in delayed access to care and treatment, and possible transmission of their infection to their partners and contacts. In recent years, there have been legal challenges when states did not provide hepatitis C treatment in state correction settings. Many of these cases argued, following a 1970s Supreme Court ruling, that inmates' medical care is a constitutional right. Just last year, South Carolina began testing and treating state inmates for chronic hepatitis C. While we face complex challenges in a strained public health system today, there has been substantial success in a variety of geographic areas and populations showing what is possible with a mobilized community, concerted action, and directed resources. These infections are treatable and identifiable through tried and true testing and detection methods. And we know we can scale up innovations to ensure that more people at increased risk can be reached with these critical prevention services. Thank you so much for your time today.
Great, Sarah, thanks so much for all of that great information. I'm going to go ahead and open it up now to questions from the audience. So just as a reminder, you can ask questions at any time by typing them into the the audience chat box that you should see down in the bottom left. I'll give it just a little bit of time for folks to sort of percolate through this information and think of some questions. But Sarah, right off the top of my head, we're hearing about increases in drug overdose deaths after COVID. Are you seeing or concerned about increases in these diseases that are related to injection drug use as well?
You know, we are really very concerned, I think, about many health conditions. We know that many of our public health staff have been redirected to working on the COVID response from other programs. And we know that preventive services have decreased, which may lead to fewer diagnoses, which is likely an indication of not detecting a problem, but not necessarily a decline in actually infections. We are concerned that when people seek out care for their infectious disease services, they're being turned away or discouraged from going to those facilities for care because of the risk of acquiring COVID or adding to the strain on the existing healthcare system. As we've discussed, we know that some of these facilities may be missing opportunities to screen people that are at risk for our infection. So it is kind of a double whammy that we're afraid of. And we do expect there to be some delays and interruptions in our gathering of data for us to fully understand what the problem is, and which will delay our ability to respond as effectively over time.
Great, thank you for that. And then we do have this question that just came in from Mississippi. I'm curious how many states are utilizing SSP programs. I know we looked at it briefly through a Winnable Battles initiative, but it's not always seen here as a popular option. Are there multiple other states already utilizing these with any return on investment info available to help prompt its discussion or usefulness?
Yes, there are many states. That's great. There are many states that are using syringe services programs or variations of them. Some states call them different names. We actually, one way that I can give you a quick indication of how prevalent they are across the country is that CDC, in order to use federal funds to support the implementation of syringe services programs, a state must apply for what is called a determination of need and submit to CDC data showing that they are at risk of an outbreak for hepatitis C or HIV. Over 40 states and multiple territories have already done that and are able to use federal funds to support the implementation of syringe services programs. We also do have some data on our website talking about, in a recent journal publication, about what the laws say to support enabling SSPs environments. We could certainly follow up with a brief summary paper that's available that shows where those states and those laws are. And I also, we do have some of that initial return on investment data about, for instance, the Philadelphia paper that I mentioned earlier in my presentation. And I think there's a couple other examples too. We'd be certainly happy to provide that information.
Great. That sounds great. We're happy to pass those pieces along to folks. It looks like we do have just one more question. What are the best strategies to combat racial disparities in infections? Are there certain care settings where testing can be most effective?
That is a great question. I think that we know that there are a number of barriers that make it difficult to address the racial and ethnic disparities that we see. Stigma is a barrier. We know that people have distrust of the medical system for good reason. And we also know that people have not been cared for in ways that are culturally responsive. And so I think that we can follow up certainly with some additional information about some specific strategies that have been implemented. I think that it's well documented that there are great disparities. And we know that there's a need to develop more of an evidence base on the effective implementation strategies for what we need to do to truly mitigate those structural factors that are preventing people from accessing care that deal with racial and ethnic, that are due to racial and ethnic discrimination. And lastly, I'll just mention that, no, I'll stop there and we have some additional information and we'll follow up, but I appreciate the question.
All right, and we did actually have one more question that came through. The messaging around HIV has changed dramatically in the past 20 to 25 years. The conversation around HIV seems to now be confined to settings like this. Efforts to push the conversation back into popular culture is important. What can be done from a policy perspective to move HIV back into the forefront?
That's great. I think, what a great question. And I think we're hoping that with the new initiative to end the HIV epidemic in the next 10 years, that we can connect with leaders like all of you to really bring HIV back to the forefront by connecting with innovative communication strategies and also letting people understand that we truly have the opportunity to end the HIV epidemic due to the progress that we have made with science and the tools that we have, and now having that knowledge that we truly can stop HIV. And so we are hoping that over the next few years, we can bring it back to the forefront by working with you all and other partners and experts in communication strategies to do so.
Great. Thank you for that. And on the note of speaking about HIV and what can be done on that front, I'm going to go ahead and turn it over to our first legislator today, Representative Alex Valdez from Colorado, and some of the work that you were able to accomplish in the last legislative session around pre-exposure prophylaxis. Representative?
Well, thank you very much. I appreciate the opportunity to be here today, and thanks to NCSL for highlighting what is, a very important area of legislation that we as legislators can really work to tackle infectious disease. And to be honest with you, this really was not an area of expertise for me. This was my first time really working on a bill related to public health. But the reasons for it, I think Sarah, the previous speaker, really hit on some of them, and that is that I am an LGBTQ man, and as the chair of the LGBTQ caucus here in Colorado, I was looking for ways to solve multiple issues that we face as a state and as a community with one bill. And our constituents always talk about the cost of healthcare. And as we heard before, with an HIV/AIDS patient costing the system up to $500,000 to treat over the lifespan of the disease, this is an opportunity to drive down medical costs for all. But more importantly, this is HIV and AIDS is a disease that has hit the LGBTQ community hard. Even today, 150% higher rates of infection within the community. So this really was just a great opportunity working on House Bill 1061 to increase access. And from the outset, that's really what the work that we undertook was all about, was creating access points. We heard from folks in rural Colorado that beyond the issues of stigma and fear about talking with a doctor about one's sexual orientation and PrEP, we found that in many cases, folks either didn't have access to a doctor just because of the lack of doctors in rural Colorado, but also that there was a fear of talking to the doctor about it. And then beyond that, there were doctors who didn't even know what PrEP was yet, because this is a relatively new, and I say relatively new, speaking in terms of medical treatments and preventative medication. This was a new treatment. And so a lot of doctors don't know about it. So they're not recommending it to patients even when they are comfortable talking about their sexual orientation. Whereas within the community, we found understanding of PrEP was high, and what it can do and how it can prevent this awful infection that is HIV and AIDS. And so we know that by increasing access, and what the bill does is it allows somebody to go to the pharmacy to gain access to the preventative medication. And from the outset, we worked on both PrEP, which is a medication to prevent HIV transmission, but also PEP, which is a post-exposure medication. We ran into some additional challenges as we worked through that because there were some concerns about reporting of sexual assault and other matters that we felt were best left with a doctor. But when we talk about the challenges that we ran into when we were working on House Bill 1061, it was a scope of practice issue. They're getting the doctors on board with supporting the pharmacists having this additional mechanism by which to prescribe a medication was not easy. We really had to focus on convincing these doctors that we were going to go through existing protocols to approve the process we would use here in Colorado. There needs to be compensation to the provider, the pharmaceutical provider. And that was a challenge as well, because we had health plans that didn't obviously want to compensate the pharmaceutical dispensers, the pharmacists, for dispensing PrEP. So that was a challenge. And then the challenge is always, this is currently a trademarked medication. And so step therapy came into the discussion, which is using other methodologies before being able to use PrEP for prevention. And so we fought those battles and we were able to win. We worked with the doctors to create a protocol for approval of how the process will work at a pharmacy, where a patient can walk in and request the test and then be given orders to a doctor for the ongoing blood test, because there were some concerns that there could be some interactions with the liver and I think one of the main concerns that the bill brought up was, by creating new mandates on health plans and by creating new mandates for payment of pharmacists, were we going to increase the cost of healthcare to all Coloradans? And we made the argument, that we started at the top with, which is, the costs of not preventing HIV and AIDS are so much higher than spending the money now to provide people easy access to preventative medication. We know we need to do this not only in rural Colorado, but urban Colorado, and I represent downtown Denver and hear from my constituents all the time that they even worry about talking with their doctor about these private matters, and that's understandable. So if they can self-select these sorts of treatments, we feel that we can prevent further infection, and we can lower overall healthcare costs for Coloradans long term. And most importantly, and I didn't even mention this yet, but the most important aspect of this bill is we feel it will save lives, because I grew up in the 80s. I have older siblings. I'm the youngest. I'm not as young as I used to be, but I am the youngest. And I would say half of my oldest sister's friends died from HIV and AIDS in the late 80s and early 90s, and it was terrible. And so I just always thought, if there's anything that can be done to prevent or to increase access to preventing this awful disease, then it was worth undertaking. And while there are challenges, we are proud of the outcome. We've gone through rulemaking, which is the process here in Colorado by which a passed bill goes to a department to set kind of the rules. We have a standing order by order of our governor, who is also an LGBTQ man. So that was helpful to have his help shepherding this process through. Governor Polis was amazing on this. And my advice to other legislators is be very prescriptive. And I use that term, be very prescriptive about what you want your bills to do if you work in this area, because as you know, the politicking doesn't stop with the passage of a bill. When you go into rulemaking, you go into other processes, you need to be very prescriptive about what you want the outcomes to be. So I think I've used my time, so I will wrap it up there. But thanks again for having me today, and very excited that we were able to get this done here in Colorado, and hoping to save a few lives.
Representative, thank you for sharing. If folks on the line have questions, please go ahead and put those into the chat box. I am, however, going to go ahead and invite Delegate Rohrbach to go ahead and share some of the work that West Virginia's been doing with your syringe service programs. And Delegate Rohrbach will be joining us over the phone, so if you don't see him there in the video section, there's nothing wrong with your computer. Delegate, do we have you?
Yes, I think so. Charlie, can you hear me?
I can hear you.
Yeah, okay, great. Well, thanks to everybody for attending today, and thank you for having me. I'm sorry that we had a technical problem and I've had to attend by phone, but syringe services program. So I will start by giving an additional to my bio. I am a liver specialist, besides being a legislator. So hepatitis B, hepatitis C, those are, I've treated those for my whole career. And the reasons to consider syringe service programs in your various states have already been spelled out. I mean, that hepatitis C is the second leading cause for liver transplantation. So I will add, besides the cost of the medications, you got to balance that against the cost of liver transplants. And we've already heard about the bacterial infections in the heart. We've heard about HIV, hepatitis B. So we can reduce all of these with a well-run syringe services program. So there really is a very good return for your investment. Now, the other return, though, and I was the individual that helped set up the first program here in West Virginia, and I live in Huntington. And we started the first program here. And as Sarah said, the other thing that's been a constant amazement to me is how it helps people who are kind of checked off the grid for a while reconnect to the system. They start to get health care. The other thing that we found is between 30 and 40% of people that stay with the program within 1 year will go into treatment. That's a tremendous number. And we also help to destigmatize asking for help. So the individuals here will come to the health department, but we also have a program that goes out to them. So we'll do it both ways. And if you reconnect with these individuals, you can get a lot of them into treatment. when they're ready. But in the meantime, you can reduce the HIV in particular. Now, Sarah had a nice slide that I wasn't able to see, but I'm quite sure that unfortunately my city was one of the cities that's worked with the CDC because we had an outbreak. The city of 50,000 people, we had about 63 people, injection drug users, come up in a very short period of time with an HIV outbreak. So again, don't think that these things just happen in large cities. They don't. So really, there's major public health reasons to have a syringe services program. Now, as far as legislative needs for these programs, I can tell you several of the things that we've worked on and will continue to work on. One of the things, and Sarah got into that a little bit, your paraphernalia laws. Now, one of the problems that you will find out is, unfortunately, some programs, the largest county in our state, disbanded their program because of the litter associated with it. The people would get the needles and they just wouldn't bring them back. So the only thing I would urge there, when you craft your legislation, you need to make them exchange programs, because as soon as we did that in our community, the litter went away. If it's got to be a one-to-one exchange after they get started, you get them started, but then it's got to be a one-to-one exchange, your litter problems will go away. The other things, obviously, you have to fund them. And in addition to the funding, Sarah very nicely pointed out, you also need to fund the screening, because you don't find HIV, you don't find hepatitis B, and you don't find hepatitis C unless you look for it. So you need to screen to be ready to know who to treat. And then lastly, depending on your state laws, some states have passed legislation that would indemnify their health departments from people that would take a syringe service program syringe and unfortunately overdose and die. So depending on your state laws, some states, our state didn't need to do that, but I know some states have had to do kind of an indemnification law to make the health departments indemnified. And just to show you how important these are, in West Virginia is a small rural state, 55 counties and 1.8 million people. We already have 18 programs up and going. And so this is something to consider in your states, because if you really want to bend the curve on infectious diseases in the injection drug community, this is really the most proven way to do it. And I'll be happy to answer any questions or discuss with anybody the medicine behind some of this.
Great. Thank you for that, Delegate Warbach. And as I mentioned, now we can go ahead and move into that Q&A portion. And I think, Sarah, actually, you had wanted to revisit an older question on settings that are most effective for testing. So I think we can get it kicked off there.
Thanks, Charlie, so much. I realized I left answering that out. And actually, it's a great segue from what Delegate Warbach just mentioned. One setting that can be effective for testing people are syringe service programs, because they are able to engage with a population that is not embraced as much by the regular healthcare system. So that setting can be effective for different reasons. The other thing I would mention is that community-based organizations that provide healthcare services, they might be organizations that have a history of serving the LGBTQ population, or HIV care providing organizations, also can be very effective. Often those are organizations that have people that are from the community that may have lived experience in addressing these infectious diseases, and can do a great job of helping people navigate through the system and better managing their care, and can be very effective. We also think there are great opportunities in scaling up STD express clinics, where people can come in quickly and rapidly. There are some places around the country where they use those, to be able to rapidly get access to STD testing very quickly. That's a model that's been used in other parts of the world and is growing in the US. And that's it. Thank you.
Great, thank you. And then we do have another quick question that came in. How can we address concerns over needle litter and needle exchanges? And Delegate Rohrbach, you might be on mute, but I think that you kind of mentioned a strategy that West Virginia took in making sure that those needle exchanges were one-to-one. I wonder if you have maybe some thoughts there.
That's, again, in Kanawha County, which is where our capital is located, they actually closed their program down, and that's a shame, but it had to do with the litter. So don't think that there's not pushback in the community to some of these programs. So I think that's been a very effective. We worked with the police department here and the public health officials and the city, and we came up with making it a one-to-one exchange. And when we did that, that helped tremendously. So, but, you know, you can't give up. You have to be, you know, willing to modify your programs a little bit. But they are so vital. Now, another thing that's been brought up, and there is going to be legislation introduced this time. I'm not sure that what we're going to do with it, but is to make health departments barcode. So each syringe is identified, and you can trace that back to an individual that got it. Now, that's very expensive. It's unwieldy for the health department. I don't favor that, but I do know that one of our senators is going to introduce that legislation this time. So, but I think that more than anything, if you make it a direct exchange, you'll get a lot better results.
Great. Thank you for that, Delegate. And Sarah, I think that you have something to add here too.
Yes, I just wanted to mention there are also some other strategies that you can consider that can have the same type of way of incentivizing efforts. Some communities will not want to embrace a one-to-one exchange policy. I know why in West Virginia that's been the route they have gone. In other places that may not work as well. And we can incentivize returning of syringes. And we also can do things with rebates for food and other vouchers, food opportunities to access food and other services that people may not access anywhere else that also will help bring needles back into the syringe service program so they can collect them. And also a lot of times people that are affiliated with the syringe service programs will take part in community cleanups and ensure and really be more proactive than it would have been before the syringe service program in ensuring that needle litter is addressed.
That's excellent. Thank you so much. I do think that there's a few more questions that have come into the chat, and I want to get to them. But first, just very quickly, I want to, as we kind of come up to the top of the hour here, make sure to wrap up with some NCSL resources and make sure that folks know how NCSL can help you as you move forward into the legislative session. We have a number of databases that track very specific kinds of legislation and publications that really span health topics from A to Z on our specific health portal pages, but we can also help with really anything that you're going to be addressing as a legislature or as a legislator in the upcoming session. For instance, I have included in this slide just a few examples of the different sort of legislation on the issues that we have talked about today. In the issue of time, I'm not going to go through each specific bill here, but you folks can download those from the resources tab and take a look if that's of interest to you. I do also want to highlight that if this presentation today was helpful for you, that NCSL can virtually come to you as well. We do offer a technical assistance to our members wherein we can actually connect your committee, your staff, or other colleagues to CDC experts, other professionals for a really tailored sort of informational or educational experience. We were able to do this through our partnership with CDC in Kentucky in 2019, where we were able to provide really tailored information and a CDC expert that addressed their specific questions and challenges that they faced in implementing their syringe service program laws. I do also want to quickly highlight our upcoming webinars and just make sure that everyone has my contact information if you have further questions or want more information, or if any of those opportunities are of interest to you. But then I think that we have just two final questions left to address in the audience chat. And Sarah, I think this first one might be for you. Is there a place that folks can go to figure out which of these infectious diseases are most prevalent in their states?
Yes, we have a resource we call Atlas on our website where you can actually go and do searches and download information about your state, down to the county level for across many of our infections and many different aspects of our infections, including demographic data. And that information is provided in some resources that will be available with this webinar.
Yes, and thank you for highlighting that. If you go into that resources tab, again, we do have a link to that resource. So if you want to just get on that right now, you can, but we'll also follow up by email. And then finally, with COVID-19 in mind, are there one or two strategies you'd prioritize for this legislative session?
Yeah, I think one thing to keep in mind is that how you can combine what you are doing to address COVID for testing or vaccination efforts with addressing other infections. Leverage the existing infrastructure you have in your state with your HIV prevention and care service programs to ensure that you can test and vaccinate people for COVID and also get them tested for HIV, get them tested for hepatitis. Allowing some scope of practice changes to allow different people to be doing that testing or rapid tests can be very helpful and will help probably prevent future problems that we may not know about yet and down the road, that we don't lose sight of testing for these other infections. I think the other is allowing for self-testing initiatives where we can work with states to make sure people are getting HIV testing at home or self-collection for STDs where they then bring it in to drop it off. Providing opportunities for those types of strategies to take place can be effective as well.
Thank you so much for that. And I wonder, Representative Valdez or Delegate Rohrbach, if you have any thoughts on going into this next session with COVID-19, are there any strategies that you'd recommend legislators prioritize for this legislative session? Don't mean to spring it on you if you haven't thought about it.
Well, I can certainly answer that. First of all, there's a lot of evidence that there's been a tremendous upswing in the SUD during this pandemic. And I think we're going to have to all analyze very hard in our health committees why that's the case and what we can do, because there's no question that overdoses and substance use has went up during this. And this is something we're going to have to get back on top of.
And I would just add that I think what COVID has done is, again, further highlighted the disparities that we see in health outcomes in communities of color and poorer communities, and that we should build upon access strategies that'll come from COVID. Like Sarah said, we should continue to build onto the infrastructure that we've had to hastily put together. We should make it permanent in the communities that need it most and expand the care that's offered there.
All right. Thank you both so much for that. And we are at the top of the hour, so I want to go ahead and thank everyone for joining us today. I know that you have many competing demands for your time. So I'd like to thank Sarah, Representative Valdez, Delegate Rohrbach for speaking with us today, and everyone else for joining us. And I hope everyone enjoys their afternoon and is off to a great start in 2021. Thanks, everyone.